Assessing Cardiac Function Using Basic Clinical Assessment by Melissa Pride. Our objectives today are to provide visual and educational context relating to your performed bedside patient assessment findings with effective preliminary evaluation of cardiac function. This includes heart rate, heart rhythm, pulse pressure, evidence or lack of evidence perfusion, cyanosis, and more. Also to recognize simple non-invasive measures of cardiac function. Heart rate is measured or observed by palpation, auscultation, EKG, and other means of measurement. Blood pressure can be measured with a blood pressure cuff, but it is felt by palpation. This is called pulse pressure. It can be calculated by dividing the systolic blood pressure by the diastolic blood pressure. Heart rhythms can be measured by EKG, but they are felt by palpation. Here's Fred. He's an average guy, and the average heart rate's between 60 and 100 beats per minute. To measure pulse strength, we use a scale of 0 to 4, where 0 means the pulse is absent, 1 to 2 means weak and thready, 3 is normal, where Fred is, and 4 is where the pulse is bounding or very strong. Radial artery pulse palpation. The radial pulse is one of the most common locations where a pulse can be checked. What is the quality of the pulse that you feel? Is it regular or irregular? Is the pulse too slow? If it's less than 60 beats per minute, we call this bradycardia. If the heart beats too quickly, over 100 beats per minute, we call this tachycardia. Is the pulse that you feel weak and thready? If so, this could be caused due to a decrease in stroke volume, such as what happens with hemorrhagic shock. If the pulse is strong and bounding, this could be due to anxiety, heart disease, or other valvular conditions. Carotid artery palpation. When palpating the carotid artery, you want to select either the left or the right side. You do not want to palpate both sides bilaterally simultaneously. This can cause harm to the patient. This can cause decreased blood flow to the brain. It can also increase pressure, causing a vagal stimulation. If comparison are weak, this could be cardiogenic shock, and if they're strong, it could be aortic regurgitation. Another important pulse is the apical pulse. While this cannot be palpated, it can be auscultated by following the suprasternal notch to the angle of Louis, down to the second intercostal space, continuing down to the fifth intercostal space, and over to the midclavicular line. If after assessment of the apical and radial pulse there is a difference of plus or minus 2, this may be an indication of atrial fibrillation. Femoral artery pulse palpation. The palpation of the femoral artery typically takes place when peripheral pulses are weak, thready, or undetectable. This can take place during physiologic shock or during cardiac arrest. If there are irregularities in the pulse, this could be due to vascular dysfunction. Popliteal artery palpation. To palpate this artery, locate the artery behind the knee, and it can be found bilaterally. When these pulses are exaggerated, it could indicate an aneurysm. If the popliteal pulse is decreased, but the femoral is normal, this could be a sign of atherosclerosis. Palpation of the pedal pulses. This can be palpated in two locations, either the posttibial or the dorsal pedal on top of the foot. If these dorsal pedal pulses are absent, this could be a congenital reason. If the pedal pulses are diminished, this could indicate peripheral artery disease. Two methods of measuring blood pressure non-invasively are using oscillometric automatic devices or using the traditional measurement with auscultation. The validity in the measurement provided by these devices rely heavily on the size and fit of the cuff around the arm and the integrity of the internal bladder to maintain cuff pressure. Calibration of the device is required to ensure a valid measurement. If a patient experiences a decrease in cardiac output, this stimulates the sympathetic nervous system, causing an increase in heart rate and an increase in peripheral vasoconstriction. This vasoconstriction causes subtle elevations in diastolic blood pressure. Observing these trends, both an increased heart rate and an increased diastolic pressure, may alert you to pending crisis before other compensatory mechanisms fail. Elevated systolic blood pressure is a late sign of compensation. Other signs that patients may be experiencing a change in cardiac status are sluggish capillary refill, diaphoresis, or a decrease in urine output. Pulse pressure is what you feel when you palpate a pulse. It can also be calculated by taking the difference between the systolic and the diastolic blood pressures measured. This is in millimeters of mercury. Pulse pressure is influenced by stroke volume and arterial compliance. Changes in arterial compliance are not rapid. This means any changes in the pulse pressure over several beats reflect a change in stroke volume rather than arterial compliance. Low pulse pressures can be a sign of decreased cardiac output and even an advanced sign of heart failure. Elevated pulse pressures are caused by an increase in stroke volume or an increase in pulmonary vascular resistance caused by dilation. This is seen in sepsis. Pulse pressure can also decrease if a decrease in systolic blood pressure affects preload, such as in a hemorrhage, or if contractility is decreased, as in cardiogenic shock. Electrocardiogram, EKG, or ECGs are used to measure the heart rhythms that you previously felt when palpating pulses. EKGs use electrical impulses to measure the millivolts exerted by the cardiac muscle during systole and diastole. ECG monitoring can be in the form of a specific time frame or continuous monitoring. You can see P waves, QRS complexes, and T waves on these strips. It is very important to palpate pulses and coordinate those pulses with the electrical impulses visualized on your EKG monitor. Sometimes no pulses can be detected. If no pulses are detected, begin compressions immediately and activate your hospital's emergency response system. Heart sounds, or heart tones, are another means of non-invasively assessing cardiac function. The four main areas where to auscultate heart tones are the aortic, pulmonic, tricuspid, and mitral areas that associate with the valves in that heart region. We'll hear from Carol Jacobson of MedEd, a registered nurse with over 40 years of clinical care experience.
Or talk about the different sounds that the heart makes. First of all, the S1 sound is closure of the tricuspid and the mitral valves at the onset of ventricular systole. When the heart goes into systole, as illustrated by this picture, the circles are surrounding the tricuspid valve and the mitral valve, and the little arrows on the ventricle are to indicate that the ventricle is in systole. So when the ventricle starts to contract, the tricuspid and the mitral valves need to close so that blood won't go backwards into the atria. And that's what creates the S1 heart sound, is closure of the tricuspid and the mitral valves. The S2 heart sound is closure of the pulmonic and the aortic valves at the beginning of ventricular diastole. So when the ventricles relax, the pulmonic and aortic valves need to close so that blood doesn't come backwards into the ventricles as they're trying to.
Thank you for joining today's presentation on assessing cardiac function using basic clinical assessment. To summarize today's presentation, we explored non-invasive methods of assessing cardiac function. We discussed methods of recognizing cardiac insufficiency using these non-invasive clinical findings, and we discussed cross-reference of assessment to qualify the monitored values of cardiac function. Thank you.